Welcome to the October Fireside Chat. I guess I should stand up now that we got an audience. I sit at my or stand at my stand-up desk. Every now and then I'll sit on a stool, but oh, they were in holding. So okay. Today we have a special guest. Amy's joining us, and I met Amy. I don't know. I was going to say 2 years ago. I don't know if that's right or not, but I've sat through a couple of her presentations over the years, and always thought she did a phenomenal job at just talking about the industry that we live in. And she works for Health Rosetta. And Lindsay, you can go to the next slide here too. But works for Health Rosetta, well embedded into that space, which obviously the 6 degrees reach gets into, all sorts of self-funded and now we're actually into the regional health plan space as well. But Amy's more on the self-funded side with Health Rosetta. So she's going to be talking about how Unbundled isn't always plug and play, which is funny because I used to have a tagline in some of my early presentations when we were building 6 degrees that we'd created a plug and play model, and I still believe we do, but I would agree that when you go fully unbundled, all the different moving parts of that definitely isn't plug and play, but we try our best to make portion of that we do as easy as possible to work with and take on as much as we can. So Amy, I know we're 12 minutes behind. Hopefully we can make up ground through this, and I'm sure as the professional you are, we'll be able to do so. But and I feel bad for everybody. You guys missed all the banter we had. I mean, we had some good stories. We learned about, Houston and Southwest Washington and my
Arkansas,
my lacking desire to have goats and cows at my house, and Arkansas and all the things. But maybe if the recording goes out, you'll be able to catch up to it. So. All right, let's get this thing going, Amy. I'm going to turn it over to you. And Jackie,
for sure.
Thanks, Jackie. Jackie's cracking me up today.
So hey everybody, I'm so glad that you were able to join us today. I'm very honored to be here to talk about Unbundled. It's funny, Heath, you said an unbundled bundled solution, and that there was a solution for it, and there really is. You just have things that you need to think about before you're creating any chassis that you're going to put an employer health plan into. And so I won't expand necessarily on that, but I do think you can definitely create repeatable processes to make it smoother for each employer plan. So,
which is one of the things I know that Health Rosetta is focused on. It's also something that 6 Degrees has been involved with in assisting with Health Rosetta, but in the programs, especially for reference-based pricing that we've been building out, or what is best practices, what's that look like, and there's different spokes that you can take out of that wheel that make sense for certain clients, but try to make it as easy as possible for folks to adapt to. So.
For sure. So just quickly about me, when younger years, I would tell you how many years I had in this industry. I stopped doing that when I hit a certain age, and now I just say a really long time. Mostly operations, so healthcare operations. Building health plans. I worked for one of the BUCAs for a large number of years, and either worked in or led every operational team that goes into building a health plan. So I've got that experience there. I really use it to look at process improvement. How do the pieces fit together? And that's really what we're talking about today, is how do you put the pieces together so it's as seamless as possible whenever you're unbundling your health plan. So Lindsay, if you just want to change the slide. Okay, so, about Health Rosetta. So, first off, our mission, it's really to restore trust and value to healthcare. We have what is, we're actually 3 things. If you think about Health Rosetta, we are a framework of building high performance, transparent health plans. We refer to them as Health Rosetta style plans. We look at health plans as if they're, when they're unbundled, that they're components and they're levers that you put together. And so first of who we are is that blueprint. So word was escaping me for a second. A blueprint of how to put a high performing health plan together. And then we're an advisor program. We have a certification program that we have 240-ish advisors in the program today. And it's about getting them introduced to the strategies, how to, educational resources, the right vendors such as 6 Degrees, making that introduction and create an ecosystem where like-minded folks are coming together to be able to improve the health plans that employers have. So, and the third is it's really, we have an operations side of the house, and I lead the client success team. We are healthcare nerds and geeks, and we get all excited about checklists and data and collaboration and how to make the pieces work together. And so we oversee, our role is to help the employers really meet their fiduciary responsibility. And so the services we provide do that. If you want to change the slide. Did the slide change? It didn't slide up, change on my screen.
Not quite yet. We're getting close.
Okay.
Frozen on my
I thought maybe I froze because we were having windstorms earlier. So
I think it might be my computer, if you can hear me.
We can hear you. There you go.
There we go. And I did go quickly through that because I want to make sure that we're spending time on this. And so, really, why are we, what are we talking about today? And so there's some key things, and we're going to go through some practical steps to some areas that can go bump in the night, and some practical steps for controlling that. But really, it's about unbundled plans. They're supposed to create flexibility, and so building a health plan that meets the needs of the population you're building it for. But they also demand coordination. When you've got more cooks in the kitchen, who's doing what and how are they doing it, and how do they work together? All of those things are important to know and to have a strategy for. And when you pull in vendors together, vendors typically work in silos, and that's not saying anything negative against the vendors. They have jobs to be done, and they're focused on making sure their tasks are done. And so when you're pulling multiple vendors together, you need to understand what their roles are, and just know that when vendors don't communicate, that's when bad things happen. Again, one of our roles at Health Rosetta is to make sure that the employers are meeting that fiduciary responsibility. And a lot of that comes into setting that foundation for how that health plan is operating. So really on this session, we're going to focus on the practical steps to make unbundled plans work, really. Lindsay, if you want to change the slide. Poor thing. So I should probably back up and make sure that it's clear. When I'm talking about unbundled plans, so there's traditional plans and there's unbundled plans. So traditional plans, think about the carrier. It's one neck to choke, so to speak. And when you have one phone number and one team, and that team is handling everything internally to make the health plan operate. When you're looking at unbundled plans, it's many vendors that are coming together. So that coordination is key. From a Health Rosetta perspective, we think of a health plan as having that we refer to them as shipping containers, but they're really levers. And so there are specific levers that can be pulled when you're building a health plan. And those could be focusing on, pharmacy or strategy for high cost claimants. It could be your, an open network setup similar to what 6 Degrees would support for you, value-based primary care. There are these different levers that can be pulled, and those levers are generally handled by multiple vendors. And so when I say unbundled plans, it's multiple vendors coming together to serve the needs of that population. Heath, I'm going fast. You think my speed's okay based on our time?
Well, I mean, we had a 12-minute penalty box there, so I think we're probably good. But we should be good based on the slides in front of us. Just dive into them, and hopefully the audience starts asking questions too. So feel free to use this time to engage in the discussion. But no, we're good.
Okay, cool. Lindsay, you want to change this slide? Okay. So these are 5 common failure points. They are kind of more categorically, but important to call attention to. So number 1 is eligibility and data feed errors. Vendors need to know, who's on the plan. They need specific information. It's important to have a plan for making sure that the vendors that are that are working for the health plan, how are they getting the information? For example, eligibility. So eligibility typically initially goes to the TPA. The TPA's got to share it out. If you're bringing in a pharmacy benefit manager that the TPA hasn't worked with before, that requires an integration, or maybe 6 degrees from a balanced bill support, out of network support. There's an integration that needs to occur. So understanding what vendors are in place, how they work together, and what are their integration needs, super critical. The biggest that's a big pain point for members whenever that need's not there. Number 2 is stop loss disconnects. So you're bringing together vendors to serve the need of the population. It's important for stop loss to know what vendors are in place. So you could build the best strategy, but if the stop loss carrier doesn't know what vendors you have in place, you could have problems with claims that aren't paying the way that they should. So maybe they've processed through the plan's paid them, they now qualify for stop loss repayment, and stop loss doesn't recognize that vendor. So there's disconnects there.
On the stop loss side, I feel like it's gotten a lot better over the, let's say the last 5 years. But I still hear about issues that are coming up, and it always surprises me, some of the stop loss folks that are just now, kind of getting their arms wrapped around RBP. I mean, are there some common failure points that you guys are seeing, or things that you'd recommend avoiding, or questions to ask perhaps?
Yeah, so that's a great question. So there are a number of stop loss carriers who do understand and know to ask questions or collect the right information for RBP. Most of, throughout forever, it was more about what network do you have in place, because they've built their actuarial rates around that network that's in place. So from an RBP perspective, if it's straight RBP, so you've got combinations, right? But let's say it's straight RBP, meaning you don't have a Buca, a Cigna, a Blue Cross, and Aetna, United in the mix. It's making sure that you're determining what the right reimbursement rates are, that your plan is going to pay. So most stop loss carriers, they will accept claims that are up to 200% of Medicare. So if you've got a plan in place that is routinely paying higher than that, maybe based on your geography that you're going to have to pay higher than that, you want to make sure it's clear to the stop loss carrier of what that band is, and get acceptance from them of what they're willing to reimburse when that claim gets to, a spec or ag claim. I'd say that's one of the biggest. The other is many stop loss carriers now take off decrements for specific vendors being in place. I like to ask the carriers, who do they like? Who do you like for, XYZ? Who do you like for infusions? Who do you like for these things? And then bring them in, and then go back to the repricers, such as 6 degrees, and say, do you know them? Do you have experience with them? What should we think about if we're going to direct contract with them? And then working with you to get that direct contract in place.
Yeah. One of the things that I feel we've been fortunate on how we've designed our solution set is we typically see pretty aggressive underwriting. One, we have a PBM. I think that's attractive, the stop loss community, but we also have, larger claim cost containment levers built into it with payment integrity and things. So that also drives that. But I would, I'm not here to say you should only be using 6 degrees for RVP for the folks in this audience, but, make sure you're aware of the different fee structures and inclusions of the vendors that you're working with, because that will impact your stop loss underwriting. So,
just to add to that, I love a PBM. I love being able to estimate what my costs are going to be. So often I have a lot of conversations with advisors and employers about admin versus claims cost. And so standardized admin cost, higher admin cost when you've got a PPM. Some say, "Ooh, that's higher," but I say, yeah, but it's standard, and it's a foundation, it's consistent, and you know what you're going to be spending.
Yeah, we offer we offer both, because there's definitely a group of people out there that like having or reducing or eliminating the fixed cost, and that does, having the variable fee schedule does offer you that ability. So there's reasons why people may do that. So we do both, but it's up to the advisors and the plan to make that decision. But I feel like most people lean towards PEPM with our model anyways.
Yeah. Yeah. Okay.
All right. Sorry for getting you sideways on
No,
that
no,
one.
no, no. I love it. I love it. Pharmacy versus medical misalignment, that's mostly around specialty drugs. And so there are strategies that get deployed to try to control the cost of specialty drugs, but being clear about, are drugs running through the prescription benefit plan? Are they running through the medical plan? And then who's making sure that the members know where to go? How are the claims coming in? How are the claims going to be paid for? And so that's a big failure point. I hear often of well, we're going to pull the specialty drugs off the medical side and we're going to move them to the prescription benefit side. And there are some pluses to that, but there's some negatives to that too, that need to always be considered. Member experience breakdown. This is, the kind of the old who's on first situation. This is about making sure the members understand where to go. So you can build the best strategy in the world. It's a golden arch health plan, but if the members don't know how to use it, they don't know who to call. They don't, they don't know where to get guided to. That's a breakdown, and that's going to be a failure in your health plan. And then yeah.
I was going to say on the member experience, you're looking at this from, the kind of the global perspective on the whole vendor stack. But I know just like the role that we play, that's an area of extreme focus for us. And I can only imagine as you kind of put all the different players in place, how that can be a domino effect if everybody's not doing their part. And we do see quite a few options where people put like a concierge or a front person in place that kind of helps gather everything for folks. But I would say that's one of the most important components, and especially when you're running an RBP or an unbundled plan, that member experience determines everything. And say I'd make an argument it's kind of the new battlefront for vendors like ourselves is creating something that looks, feels, and operates very much like a traditional plan that delivers the cost savings that people are looking for. So
yeah. People are going to call generally the number that's on the ID card. So making sure that the member is getting to the right place for the right reason, whether that's a call tree at the single phone number or every single call goes to someone specific. I was telling Lindsay when prior to you hopping on the call is that a plug for 6 Degrees, and that y'all do an amazing job of provider outreach and making sure someone, they're going to accept their health plan and helping if there's any issues on the back end. And so making sure that there's a team that, and some of that's technology these days, but where is the member going to figure out how are they supposed to use their health plan and who's going to help them through that experience is key.
Yeah, as my young kids would say, our operations team is cooking right now. They're doing a great job. I'm very, very happy about it. So it's been a big benefit to the plans that are with us. And
love that.
I'm
Remember, this is recorded,
that.
and they're going to watch this and know that you.
I know they're going to think my dad is so much less cool than they already thought I was, but that's okay.
All right. And then the last, not least, is compliance and fiduciary risk. So, really there's 10 key areas that an employer is responsible for regarding their health plan. Happy to run through them if you want me to, but really 10 key areas. And so, making sure that they're mostly around making sure that the dollars that are tagged for healthcare expenses, that they're managed appropriately. And that's, making sure you've got the right contracts in place that set the right terms, that make it clear what services are being performed for what amount of money. And then plan documents, understanding, what is your plan paying for? What is the plan's responsibility? What's the member's responsibility? And there's a whole lot of other things in between, but those would be the 2 key areas that we target most, is the right contracts that support the right benefits that are in place. And then, of course, making sure that all the federal requirements are met. We get more and more federal requirements the employers have to go through each year. And so making sure you've got the right partners that are going to give you the right information for you to be able to meet those requirements.
So this question may be out of place, but you mentioned it earlier, so I'm just going to ask it. One of the things that we see a lot of, especially over the last 24 months or more, dual options. So as plan size increases on groups that are coming into this unbundled space or RVP space, you're seeing more of these larger plans elect a dual option type environment where they'll run, parallel an RVP plan and then, a PPO type plan, give the member the option. Are you guys seeing anything there that the audience should be aware of, or things for consideration? I know that it could impact stop loss, it could impact open enrollment, any of the things to keep an eye on.
Yeah, yes. I would say first and foremost, it's making sure that the employer understands the difference between, network and RVP. There are some folks that, only buy Levi jeans. And so there are some folks that definitely want to have that network logo on their card, and they're willing to pay for that. We are seeing typically, and unless the employer is kind of spreading the cost across the population, we are seeing an opportunity for much lower rates on the RVP. You've removed the network cost, you've hopefully reduced the reimbursement rates for the actual claims that come through, and so therefore stop loss is offering better rates for RVP. And so, to me, it's about education, making sure that they understand how the plans work, and then making sure you have the right vendors in place that are going to support it. So there are things that are different about, there's government regulations around, network and what the networks can do, and those are removed whenever you don't have a network in place, such as balance billing. And so making sure that you have the right players in place that are going to give you as the employer comfort that all of those issues are going to be handled. So we make sure education is a big piece of that.
Yeah. Okay. Okay. How about I know what we're seeing, but what are you guys seeing for election RVP versus PPO when you have a dual option?
Yeah. Interesting. Typically year one, it does depend on the size of the employer, but I would say overall, typically year one, we are seeing more that move that are sticking with the network. And then, year two, it's throughout the year, they've heard it's cheaper and I got to keep my doctor. And so there is that transition year two where more folks are moving into that RVP world because they know that there's a solution for it.
Yeah.
Is that what you're seeing too?
Oh, I was just wondering if you had percentages. I mean, I would say, 50 to 70% first year on the RVP side, or 50, and then they migrate towards 70. And eventually, if things are running as is or should be, a lot of times they'll do away with the PPO eventually. But
without a doubt, I love a good health plan that's got RVP and then it's got direct primary care. And so you've got all of the primary care needs that are needs that are met because you've got direct primary care where members are able to go to, or if I'm talking about direct primary care patients, are able to go see their provider. It's a subscription cost, not costing them a dime. Except for the subscription, unless their employer is paying for it. And then RVP, the RVP partner, the DPC is working with them whenever there needs to be referrals, whenever they need to operate outside of that primary care world. So that's my favorite strategy is DPC as the foundation and then RVP wrapped around it.
Yeah. Yeah. And if you can get the right data in the hands of DPC and have work together, one of the things we'll provide is a data feed, so they can see, who's contracted, who's RVP friendly, and that can help significantly on guidance towards, access to care and lack of balance billing. So all good things.
For sure. Are y'all I can't remember, are you a red, orange, green?
Overall green. All green. All in all the time. No. No, so we do distinguish between who's contracted, because we have our Pro Plus, which is primarily contracted physicians. We do support it with an RVP wrap as well. And then we also identify who is RVP friendly. And so we have an algorithm that we run that keeps that on a current status. So it does provide, a really nice navigation piece for members. So that's available through our app, or, if you're working, directly with a concierge, we feed that same data feed to them. So they'd have that same ability to have the conversations.
Nice.
Or medical management gets access to it too.
Yeah, technology is the way these days. So I would have to imagine you've got a lot of traffic through the app versus conversation these days. Okay, change the slide for me. All right. So 5 practices that prevent breakdown. These are they kind of wrap around what we've talked about in the 5 areas and provide you some actionable steps to be able to close gaps. And so the first is define clear accountability across vendors. So, as I said, vendors often work in silos, and that's okay. But understanding, who's accountable for what. And so we go by the concept of jobs to be done. So if you're not familiar with that, it's really understanding, why, what's the purpose of having that in place? What job are they, that product, that service, that process, what purpose is it serving? And so, everybody has a job that needs to be accomplished. And I always say, just to kind of hammer that home, is that people aren't buying products to just buy the product. So if I bought a drill, it's not because I want to drill, it's because I need a hole put in the wall. And so therefore I need a drill. And so, employers aren't hiring a TPA because they want claims process. They're hiring a TPA because they need somebody to manage the risk and control the cost and ensure a smooth member experience. Same reason they're bringing the other vendors in. At Health Rosetta, whenever my team is working with an employer and advisor, we have this tool, this exercise. It's called Jobs to be Done or Member Needs Mapping. Depending on how long ago you've had it, it's had some name changes, but it really is there's about 85 duties that the members want handled. They expect the health plan to handle. And so we actually go through an exercise where we identify who's the primary partner for that. So vendor partner, who's the primary one. And then how is that need being handled? So what's the human engagement for the member? Where's the member calling? How is the member getting to a human? And then digitally, is there something digitally in place? And then if there's a handoff between vendors, what does that look like? And so the exercise itself helps you to understand that you have the right vendors in place. It helps to start establishing what are the roles that the vendors are playing. And then it helps in evolving that collaboration of you're doing this and you're doing this and you need to work together to solve this. And so it's really just an exercise that we work through. But knowing, what everyone's accountable for is super critical for designing, how are the players working together. And if you're an employer, you're not wanting to do this, but if you're an advisor, the advisor is making sure typically that the pieces work together. Second one, standardized data and reporting. And so again, knowing what each vendor needs. It's not just the job that they're doing, but what do they need to do what they're going to do? I always think about the biggest kind of pain point. If you're thinking about member experience, the biggest pain point is member can't go get their prescriptions filled on the first of the month because that data hasn't been shared. And so how are all the data pieces coming together so that the health plan is operating as one? Remember, you're trying to build this unbundled bundle so that everyone is working well together. And you mentioned, Heath, that you make it to where data is available for the DPCs or for the navigation team or whatever the case may be. So that's definitely, you've identified a need, and they need to understand who can they access or who can they refer to support that patient.
Yeah, I mean, we've always taken the approach of transparency and working well within the vendor stack. I mean, even our name kind of reflects on the different points of contact, but not everybody plays the same way out there as far as the vendors go, and I think at times can be difficult for plans as you have that rub between different vendors in the stack. So we try our best to make ourselves as flexible as possible.
Yeah, for sure. Okay, establish governance rhythms. So who's actually monitoring the group? Everyone has duties to do, and so that's got to be overseen. And the next one is about a quarterback, so I'll just put that together. But actually put the last three together is how are you overseeing that plan? How are you making sure all the pieces are done? So you've got implementation. That's when all of that's an onboarding process. All the vendors are ramping up. You've got or backing up, you've got strategy and how do the pieces fit together. Then you've got implementation, is onboarding, and then you've got a plan that's live. And so the work doesn't go away once the plan is live. It's continuing to have that oversight of how that plan is running. Typically, it's if Health Rosetta is in the mix, it's my Health Rosetta team that's overseeing much of it, but making sure that the things are running the way that they should. That oftentimes the TPA has the largest lift whenever you're building a health plan for the first time, typically, and it's expected that the TPA is the one owning all of the steps that all of the vendors need to do to get up and running, but that's not true. And so having a quarterback that is going to oversee that is super critical. And it's not a hard task. It's just making sure there's somebody that's making sure, things are checked off and things are done. And so, with that documenting tracking issues, I love to have meetings that have everyone. And so, having a single monthly, quarterly, whatever that looks like meeting with the different vendor partners are there to be able to talk about what's working well, what's performing well, what's not performing so well, and how do we react together. It helps to ensure that things aren't missing. It allows people to hear. So oftentimes, at least in my own experience, I don't know how I might poorly be impacting somebody if I don't know that I'm impacting them negatively. I just go about my merry way doing whatever I'm doing. And so it just creates that relationship where you are a bundled partner approach working with each other. Yeah.
Sorry. Did you get through? Hold on, you keep going. I got a couple things that are percolating in my.
No, you go, please.
My little head here. As you look at these vendor stacks and the different practices that are necessary for execution, we have timeframes that we think are needed to get these plans live, and we have groups that started this process in May, and we have groups that are still in the sales process right now that you're like, hey, clock's ticking. We're
TikTok.
What do we have on the 22nd of October already? And in the end, we get these things done, but obviously more time is better. But what do you guys see? I mean, you probably see it all. How do you get everybody coordinated to success?
Yeah, that's a great question. So first, it is the right, you've got the right amount of time, and that right varies. Fourth quarter is especially fun to put timelines together. But, I love a good 180 days to get a group from I've determined the strategy, pick the vendors, and I'm ready to rock and roll and get everything loaded. That's not reality, however. 60 days is probably closer to that. The smaller the group, usually the less time you have to onboard because they're making late decisions because they've got information late oftentimes. But it is important to understand the timelines that everybody takes. And so thank you for bringing that forward. That's a key thing of, you've got these vendors, what amount of time, do they have existing relationships so they know how to work together? Because if so, a lot of that hard work's already done. Are you doing something that may be outside of their normal scope of services? Are you asking them to do something else? And so that takes time. And, do you just have enough time in general? So oftentimes I spent a number of years at a TPA. And so I think TPA often, it's so much focus, and there should be focus on when is open enrollment going to be so that the eligibility census can be put together, the TPA can load it, the TPA can get it out to the other vendors, and ID cards can get in hand. And that usually is when are ID cards going to get in hand? And there's so many other things that go with that. But being realistic whenever you're meeting vendors, what are your timelines that you need to be successful? And sometimes there's a push and sometimes there's not, but that you honoring them. And quite honestly, the more if I'm creating a partnership with 6 Degrees and I'm a broker and I'm always, my strategies are the same, we have that relationship and I know how much time you need, and it helps me set appropriate expectations with my clients. So I would say repeat business is definitely key.
Yeah. I mean, if I look at this, I'd say, the vendors that are already working together simplifies things significantly, especially the relationship we would have with a TPA, because you got to get EDI and everything else set up. And I like to say that we'll move as fast as people will let us, but some of those things, especially from the EDI standpoint, take time to set up. So as long as we have the TPA and the RVP vendor in place working together, I think that helps significantly. But then, just from our side, we offer things like, on-ramp and call ahead and that outreach piece of things. So, for us to execute on all the things that we offer, we do have to have some time prior to, their first visit, so we can make those calls and get people in the door a little bit easier. Not to say that you couldn't start the plan without that happening, but it definitely, I think, helps to have those things in motion prior to services being rendered.
Yeah, for sure. Even, continuing on that thread, does the employer have access to claims data so that they know where have their members been going to providers?
Yeah.
Or is it some, I don't know, form, and I've seen it, I can't remember if y'all do it or not, but to, designate or recommend an outreach or whatever that looks like, what is the process for which you're identifying even the providers that need to be connected? So that plays into it for sure.
Yeah, and that also, it's not for unbundling this, ball of thread here. If you're going from self-funded to RVP, you probably do have some claim data, but you see a lot of groups coming from fully insured or whatnot, and they may not have anything to have us, scrub. So then you become more of a, nomination, which for us, you can do through the app, or you can submit, through the open enrollment process. But again, that all takes a little bit of time to get in the door. So we do have a question that came in. And thank you, Wade, for that. How do you help your client from being overwhelmed with so many changes?
That was where I was going right before you said you had questions. Was it the way I'm explaining it? I'm really a Debbie Downer as I'm saying these things, but it really, it sounds like it. It sounds super complex, and there are extra things that need to be done, but it's really helping them to understand why you're doing the pieces. And so, a very clear strategy of, I start with, collecting enough information to do these things and get that information over and get it started. Making sure they understand the overall timeline. These are the actions that are going to be done over the next 3 months. This is where I'm going to need you to participate. I'm going to do everything else for you. I don't need your help. It's just going to happen behind the scenes. And so just really being, straightforward and knowing your client as far as how much of the sausage do they want to, how much do they want to know how the sausage is made versus just give them a touch point and keep cruising on your own. So we have different strategies for that, but really understanding what your client wants to know how much to give them is helpful.
I would echo that, and then add with, continuous education, and helping, keep that in front of the members so that they know what to do. These plans, the unbundled approach is definitely going to be different than what they were used to, although they sure do look and feel a lot more familiar today than they would have, even 5 years ago. But getting that education in front of them and keeping it in front of them, and reminding them why they're taking this path. There are some significant benefits to going, reference-based, and the dollars that it generates that can go back into, salaries or additional services, and keeping the doors open even. But reminding folks why they're doing this, including, the ability to go to a doctor you didn't get used to go to. You do have an open access model now. Or, depending on the unbundled approach you're taking, sometimes it's a neural network with a wrap or something. But, at least in our space, it opens things up for folks.
I think so. And education is so key. I have a lot of conversations with both, broker advisors and employers of, how much information are you sharing with your employees? I think that employees should know the cost of healthcare. They should know what you're doing to help reduce those costs as much, and know what those amounts are. Now, are all employee populations, does that Is that the right level of information? No. I mean, but back to knowing your client, employers knowing their populations. But everyone should understand, the cost of healthcare, where it's going, and how employers are helping with that. At Health Rosetta, we talk about the Health Rosetta dividend, and that's really the money that would have gone to feeding the machine that's being saved. What are you doing to reinvest that? Are you reinvesting it in you as an employer? Meaning maybe you bought more equipment, or Sally was doing the job of two people and now I can hire somebody. And so Sally and Sue are sharing. So you're reducing that stress of your employees. Maybe it's giving back to your community and you're helping fund a clinic. I don't know what it is. But those savings that are occurring, and the savings are real, being very, helping your employees to understand what's being done with that money is always a valuable tool for telling them, why is this different? Why are we doing this different? And then, to your point, making sure they have the right resources to help them if they have questions, to guide them through the process.
Yeah. All right, another question came in. Hold on, before I ask it, are there? I know you got a few extra slides here. Do you want to take questions now, or do you want to kind of hold them to the end and get through the slides? And
yeah, I know that the only real last slide is about takeaway, and it's really just a recap of unbundled plans work when we all collaborate together. Make sure you get your data is aligned.
All right, let's hit up that takeaway slide, and this is a good question here that we've got that we'll bring up at the end here.
Yeah. So, I mean, really just quickly went through those 5 areas. If you target those areas, they bleed into the different things that need to be done when you're pulling different vendors together. And quite honestly, it's not to say that those aren't things that that should and could be done when you have a single, bundled option. But unbundled and making sure the vendors know how to work together, that's key. Your vendor partners, they are your partners. Whether you're an employer or whether you're the broker or whatever you are, they are partners, all playing in the same sandbox. And so just making sure everybody has what they need, sets that solid foundation, establishes that relationship to be able to serve the population.
So on that vendor coordination, I mean, if there were any words of wisdom or something you could fix on that front, what would that be?
Yeah. 2 things. One, I did touch on, but that the TPA will not manage it all for you. So making sure that you've got somebody to oversee that. But really, my biggest additional advice is that you need to understand what each vendor needs and why they need it. And so often I've been party to, and I've played different roles in this, not innocent, but party to telling a vendor something, telling them how it's going to be done, instead of saying what works best for you, what's best operationally is the right pathway for you. Because when you're following a vendor's best pathways, you get the best foundation, instead of them having to create something that's funky and clunky and not what their folks are used to doing. So, overseeing, and then what works best in the vendor's best world, and trying to follow that if it really does meet the needs.
What are some of the biggest failure points you see with the different vendors that are in place, and how that impacts the employees or the plan?
Yeah. Immediately, I see a first failure if there's not that communication during the implementation. I'll just start with eligibility. So maybe the plan is set up with a location in Houston and Portland, but at the PBM, it's not set up that way. So members are feeding over, they all fall out. Members go to the doctor, they say they don't have any insurance coverage. My coverage is junk and I can't use it. And I've said those words, so I feel like I can say them now. But making sure that everyone's ready on the first. And so prescriptions are number one. Customer service teams, they're ready to answer the call. So you've identified who does that job. You've given them the right resources to be able to educate the members about their plan, how to use it, what to do, call me back, whatever that looks like. But making sure that the members know how to use the plan is, to me, the number one, because you've got member disruption, but you also have members in that HR person's or that C-suite's office, and nobody wants that. You want them to be able to use the plan the way it's intended to use. So that understanding roles and understanding who's going to support the members first is super critical.
Okay. All right. So we got a question that came in. Member dissatisfaction is a concern for many clients. What resources are available to identify if the employees are located in a amenable, it's a big word for a guy like me, amenable community for RVP, and how do you determine if a network wrap is appropriate or not?
You want me to answer that, or you want to take a
Well,
swing?
yeah, I mean, I've got an answer from the 6 Degrees side, but why don't
Yeah.
you give it from your side, and then I'll
Yep.
chime in.
Yeah. I mean, when you're first building out the health plan, there's the 6 Degrees. There's a heat map. So do they have existing business? Do they have other clients? Do they have success with the providers in the area? How open are they to not having that traditional network in place? I typically, if it's a community that if it's an area that cash pay is a popular thing, I usually see success there because they're used to operating outside of the traditional health plan. So cash pay is a big one. I have gone to providers in the area and looked on their site to see do they have cash pay prices. That tells me they're open to not just running through a network. And so that's kind of my first step is understanding the geography for which they are, and then developing that strategy around it.
Yeah. So from the 6 Degrees side, if you were able to get any sort of claim data, we can run a full disruption report on that, which would show how does their access points line up with our Pro Plus model, which is pre-contracted. It also would run it against all our RVP engagements. So we can see, are they hitting contracts? Are they hitting locations that are widely accepting reference-based pricing? Or on the other end of it, are they accessing areas that are trouble spots? One of the nice things about the 6 Degrees model is we are willing to and can pivot to contracting to work our way around, some of those problems. But it opens up the discussion to determine, what is the best practice here and actions to take in terms of designing this plan so it works for the members that are utilizing the services. And then Amy mentioned, cash pay. So we have a Medicash program that allows for, that prepayment. It's just built into the solution. And it can be very effective to get folks to take a payment or a reimbursement that is significantly lower than they otherwise would have, and it avoids bounce billing. So, it's whether you're using us or anybody, make sure they have the tools in place to handle an ever-changing environment, because we can do that analysis today, but it doesn't promise that tomorrow that it might be slightly different if you have a change of leadership at a hospital system. Mm-hmm. So, things can get tougher or they could get better. You just have to make sure you can handle those situations when they come up. And that's one of the things I think we do a really good job with is just having a lot of tools in our belt to pivot as needed.
Yeah. If I can quickly, and I know we're at time, but the secondary part about, a wrap network, sometimes a wrap network does have to be put in place, and maybe that's okay, because then the members are going to see those providers. So maybe year 2, you're saying, listen, my folks are already going to see you. How about a direct contract? So it lays the foundation for a number of providers. They want that membership going to them. You're having an easier conversation if it's patients that they're already seeing, that you're saying it's the same population. We just want to get you under a different contract.
All right, real quick, 30 seconds. Time frame for proper implementation. From the 6 Degrees side, 60 days is what we ask. We can do it in less, but it really depends on who you pick for vendors. So quick, Amy?
I would say 60 days as well, as long as your vendors know how to work together already.
Okay. Feel free to reach out to us. Next month, we have, go ahead and keep clicking forward, November 19th, our next Fireside Chat with Christine Cooper. We'll be talking MediShield and legal built into RVP solutions and what she's seeing across the country. So thank you, everybody. Amy,
right,
that was awesome. I know we had a shorter window to operate within, but we did it. And
we did.
Hopefully everybody enjoyed it. You can watch this recording, access it from our website. And until next time, take care, everybody.
Bye, guys.
Thanks,
thank you.